All right. Hi, everyone. This is Dr. Amigues, your friendly rheumatologist here in Denver, Colorado, where it is a beautiful day. And today we are talking about scleroderma and what is scleroderma. So this is a question that one of the viewers was asking, and we'll do several series on that because it's a pretty big topic actually. And I'm going to start with a case because I think that, again, cases are really helpful. So, well, actually, I will share one of the cases that I had that made me become a rheumatologist, actually. So, a while ago, back in France, I had a patient that basically showed up because her hands were so puffy that she couldn't actually close them completely. And so she had this issue of skin very tightened, and she couldn't close anymore fully her hands and she couldn't extend them either. And she started basically seeing that, and then very soon after, well, actually after a while, developed also skin thickening of her forearm, as well as some, like she lost a wrinkle on her face, which she was actually pretty excited about, but she was losing a wrinkle. And so then, we did, we looked at her, what other systems she had that could be involved. We looked for biological confirmation, and ultimately we found that she did indeed have scleroderma. What is scleroderma? Scleroderma comes from the term scleros, which means thickening of the skin. Skin, sclerosis means thickening. Um, and basically, it's the hardening and thickening of the skin that makes it very tight. And that's why on the face, you're really losing all of the wrinkle, which is, one of the first signs that some patients actually see. They don't actually realize that our hands have become like also thickened, and they think that it's arthritis, and then they realize that they don't have any more um, uh, wrinkles of our skin, like on our face. Um, there are multiple type of scleroderma. There are scleroderma that are only going to affect the skin, and that's all it's going to affect. And it may not be a big deal. uh, you know um, some other scleroderma can be extremely dangerous because they can affect the kidney, they can affect the lungs, they can affect the heart. And so the goal when you're making a diagnosis of scleroderma is to figure out what type of scleroderma this is. Is it going to be a limited scleroderma, or is it going to be a scleroderma that's more systemic? Either way, we're going to treat you. So I think that that's really important that you realize that you're not left alone without anything. So scleroderma is an autoimmune disorder. So we don't actually really know what's happening and what's the reason why patients will develop scleroderma. But basically, your immune system starts developing an immune response against your skin and against your vessel. So basically, really, like those are like the two things that you want to think about. It's affecting my skin, it's affecting my vessel. But because it's affecting your vessel, not you, we're talking about other people. um, if it's not, if it's affecting your vessel, it's affecting actually a lot of organs, right? And that is the issue. And that's why, for example, patients who have pulmonary hypertension, there's a squirrel that just came up there. Whew. So if you have involvement of your kidneys, it's usually because of the vessel involvement. Pulmonary hypertension is because of the vessel involvement, and so on. Let's look a little bit at how we make this diagnosis. So the diagnosis is made by the clinical symptoms. We're going to go over them. And then usually we can confirm it with a positive ANA, a positive SCL70, or a positive RNA polymerase free. And, those are like the main ones. Positive SCL, which means scleroderma already. Positive SCL 70 is usually associated with more chance of developing lung disease. Positive RNA polymerase 3 is associated with kidney disease. And then we have the centromere antibody that's more associated with pulmonary hypertension. Of course, it's medicine, so nothing is 100%. And so it's really our job to look at how you not you again, how patients present. Okay. The reason I say not you is that I don't want you to think that you're going to have all of this. Even if you have scleroderma, I don't want you to think that you're going to develop all of this, because our role as rheumatologists is to prevent that. And if you do have all of the things that I'm about to share, that's okay. We are going to treat it. And now we have more treatments than ever. Okay. So that's really important. So one of the first manifestation of scleroderma is Raynaud's phenomenon. Raynaud's phenomenon is, and actually I have it. I don't know if we can see it today. Not really, but basically you would have a couple of fingers, or maybe all fingers, that are, very white, and it stops here. It's like a very obvious demarcation of normal color here, and then here white, no more blood. I don't have any, like almost here, but it's not obvious. But like for me, I have like two fingers that can become white, and I do not have scleroderma, guys. Like, right? Like it's pretty common, and it's very common in scleroderma. And what happens in the Raynaud's phenomenon and in scleroderma, right, is that you get a vasoconstriction of the blood flow. So the vessel vasoconstricts, so closes. And because of that, you don't have enough blood flow of the rest of your fingers, but also it can do that also in kidneys, and can do that in lungs, and so on. And so that's what's happening, is that you get, this vasoconstriction. You also get issues with the way the lining of the vessels are. That's like another complication of scleroderma. So that's the first thing, right? Raynaud's phenomenon is, if you don't have Raynaud's phenomenon, you most likely do not have scleroderma, because it's almost like universal symptoms for all patients with scleroderma. They have Raynaud's phenomenon. Okay, so that's like number one. And then you have the skin manifestation. So there's a ton of skin manifestation. The one that we usually, recognize is the sclerodactyly. So dactyly, fingers, thickening, right? So thickening of the fingers. And so basically you get like these hands that go like this, and you cannot, like, it's hard, and they're like puffy, and it's hard to close. And you see how you can actually see here on my fingers, I have a lot of wrinkles. Like, that's normal that I can do this with my wrinkle. Well, you cannot do this. Like, you can't. I'm going to try. It's tight. I really cannot do it on my fingers. But it's really tight. And you're like, oh, that's odd. So that's sclerodactyly. You can have this thickening of your forearm, of all of the skin, of course, if it's a diffuse form. And then you can also have at the beginning just itchiness of your skin. So it's like this pruritus, like very itchy. That's a pretty common symptom for patients with scleroderma that can be really annoying, actually, because it's itchy. Like, there's a lot of itchiness to it. So we have treatment, but it's like that's definitely a symptom that I see often in patients with scleroderma. Okay, so that's this. Then you can have joint pain. You can have tendon issues. So it's not just the joint in scleroderma; it's also the tendon, and you can actually feel a tendon rub on. If you were to do this, you can actually feel a tendon rub under my palm. If I were to put my palm on top of the knuckles here, I could potentially feel a tendon rub. Same thing for this joint, like the wrist, and so on. So you look for that. You look also for like can you open fully your mouth, or is the sclerosis so much that you cannot open your mouth, and so that's actually an important thing. And so that those are like the main skin. You can also have vessel, and so that's called telangiectasia. It's like the spider webs, but they are red, and so that is a sign sometimes that you have scleroderma. You can also have calcification or calcifications, which basically is under the skin. You would have um, a little bit of calcium deposit, and that's called cell calcification. I'm starting to wonder if I should have recorded this inside instead of outside. There's a lot of wind. I hope you guys can hear. I'm sorry about this. Um, and so that's like so I said the skin, the joint. Then I mentioned earlier that you can have involvement of your kidneys. You can have so the kidneys that can be quite dangerous, and this is why we don't like to give steroids in patients with scleroderma, because we know that it can cause scleroderma renal crisis. So we try to avoid that. So kidney, and then you can have involvement of your lungs. Again, interstitial lung disease, so the interstitium. We can also see what we call pulmonary hypertension, which is also, but it's basically more of a vessel issue in the lungs, right? Like it's so that can be really problematic as well. You can have shortness of breath, but again, we have treatment. Like this is like dealing with scleroderma today is very different than dealing with it 10 or 20 years ago, or even 5 years ago, honestly. So we have much more like really good treatment. So that's important. So I'm presenting this devastating disease potentially, but you don't have to have all of those symptoms, and two, we have treatments. But it's important to see them and to look for all of them when we are wondering if you have scleroderma or if we just made a diagnosis of scleroderma. Heart can take a lot of different aspects. So you can have inflammation around the heart. You can have heart disease due to heart failure due to scleroderma, coronary artery disease, which can lead to myocardial infarction, so heart attack that can actually happen also with scleroderma. And then I put it sometimes with it the pulmonary hypertension that we were mentioning, just because it increases one of the ventricle of the heart, and that causes shortness of breath, and that causes a lot of issues, and it causes also lower extremity edema, and that can be problematic because you may not have a severe scleroderma otherwise, but you have this. And it's actually more problematic nowadays than the lung issues in scleroderma. So that's something to know. And then you can have involvement of your GI tract. So that's also an important thing. You can actually have diarrhea or constipation. You can have esophagus dysmotility. So a lot of patients with scleroderma will have reflux, what we call GERD. And that can be an issue because you can actually, we may think, oh, you have lung disease, but actually it's not lung disease. It's just that you're constantly regurgitating stomach content into your lungs, and that can cause inflammation. So we always tell our patients, elevate the head of the bed to make sure that you're up, and then eat, 4 hours before you lie down. That's really important, 3 to 4 hours before you lie down. Those are like the main issue, right? So the skin, the lungs, the vessel, the heart, the kidneys. Those are like the main issues. We always look for all of those when there is a new diagnosis of scleroderma. And so what we do to make a diagnosis is that we look at all of the manifestations that you may or may not have, and then we look for antibodies. If you have a bunch of those the clinical manifestation, we don't need an antibody. Usually you have at least an ANA, right? But you don't need the SCL, you don't need the centromere, you do not need the RNA polymerase III. You have a positive ANA and you have some of those manifestations, especially the skin, then you have scleroderma. There are cases where you don't have the skin thickening of the scleroderma, and we can say then if you have, pulmonary hypertension and you have a positive ANA and you have calcification, or you have like the joint involvement. When you have that, it's harder to make the diagnosis, but we may say that you have, and maybe you have a SCL70, or maybe you have an RNA polymerase III. And we've seen that, right? We say that you have scleroderma, sine scleroderma. So scleroderma diagnosis without the cyst, the scleroderma, so the skin sclerosis, the skin thickening, right? So it's really more of a diagnosis that you want to discuss with a rheumatologist that has seen many cases. It's a rare diagnosis. So please don't start thinking that you have scleroderma if you have like, the Raynaud's and the positive NA. You need to be evaluated, absolutely, because we can prevent further, issues down the line. But I don't want you to freak out and think like, oh my goodness, I have scleroderma the moment you have Raynaud's. I have Raynaud's. I don't have scleroderma. Plus, Raynaud's can be associated with many other issues, right? So don't think that way. But I think it's important to kind of get a sense. And this was a question that was asked by one of our listeners / viewers. And I really appreciate, and, I'm trying to answer all of the questions that you're asking, guys. But yeah, so this is the first view. Next time we'll talk about a little bit more about how we diagnose, and then we'll go ahead with how we treat, the broad view of how we treat scleroderma. And I think that's it for today. Thank you so much for joining in. And I will, hi Tiff, I will see you next week. Oh, I have a question. Leonard Media. I have Raynaud's and psoriatic arthritis. My dad had Raynaud and RA, and his dad had RA. His mom had MS. Must be a correlation between autoimmune and Raynaud's. Absolutely, there's a huge correlation between autoimmune and Raynaud's. So, although Raynaud's is pretty common, especially in women, when there is a new diagnosis of Raynaud's, I like to see patients and make sure that you don't have an autoimmune disorder, because we can prevent further issues down the line. So, for example, you may have Raynaud's and lupus. You may have Raynaud's and rheumatoid arthritis, Raynaud's and another type of autoimmune like scleroderma, we just mentioned. And so there are like a couple of things with Raynaud's that tell us, oh, maybe this is what we call Raynaud's phenomenon versus Raynaud's disease. Raynaud's disease is just you have Raynaud's, that's it, not associated with an autoimmune disorder. Raynaud's phenomenon is you have Raynaud's and it's associated with an autoimmune disorder. And so that's something that we are trained to look for in patients who just develop Raynaud's, or, their Raynaud's is worse. But yeah, no, it's a very good point. Thank you for making that point, Leonard. All right. Well, if you are watching this as a replay, please put #replay. If you're in the Denver, Colorado area, I'm available to see new patients. I love seeing patients, especially if you're wondering if you have an autoimmune disorder. I'd love to help you with that. And otherwise, I will see you next week. Thanks for tuning in. Have a wonderful day. Bye, everyone.